Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. My guest today is Michael Canney. Michael is Chief Scientific Officer at Carthera, a clinical stage medtech company advancing brain therapy through innovative ultrasound-based devices. A co-author of more than 50 peer-reviewed articles, he specializes in neuro-oncology, glioblastoma, and neurodegenerative diseases. At Carthera, he is responsible for leading scientific collaborations with academic institutions, organizing U.S. clinical trials, and more. Thank you so much for being here today, Michael.
Thank you so much for having me.
Yeah. So my first question to people is always just trying to figure out the backstory. What got you interested in what you're doing now, and how did you get to where you are now?
So that's a complex story, but I got there a little bit circuitously. But I started working in this field of using ultrasound as kind of a therapeutic modality. Most people think about ultrasound as a diagnostic imaging modality. Those baby pictures of babies are the first things I think everyone thinks of when they think about ultrasound. But the field of therapeutic ultrasound, using it for different applications, in this case, we'll talk about drug delivery. It's also been used to kind of replace surgery as a tool to induce tissue ablation or destruction. And these are like growing fields. They're really interesting because it's been something that's been ramping up for the past couple decades, I would say, as we have kind of imaging modalities that can guide these therapies. But there's just been an explosion of research in all of these areas to use ultrasound as a therapeutic mechanism modality, I would say. And so, yeah, when I went to do my PhD, I got involved with a lab that was working specifically in therapeutic ultrasound. They had a heavy influence program in lithotripsy, which is breaking up kidney stones using shock waves, acoustic shock waves. But they also had a program around using HIFU, which is high intensity focused ultrasound, and really using very high intensity ultrasound to try to you can think of burning tissue or thermally ablating tissue. Um, and so that kind of brought me into this whole field, I think, of using ultrasound for different therapeutic modalities. After I did my PhD, I went to France to do a postdoc, and it was there that I got involved with the founder of the company we'll talk about today, which is Carthera. Was founded by a neurosurgeon named Alexander Carpentier. And he's, very kind of visionary neurosurgeon who brings a different perspective, but is interested in bringing new technologies into neurosurgery. And he had this idea, that we'll talk about using ultrasound as a drug delivery mechanism, and built this company, Carthera, when I was over there.
Yeah. So you got some really cool kind of firsthand experience with that then.
Yeah. A lot of experience. Yeah, I moved over to France and worked with Alexander. We had just a couple employees in the early days as we developed the first system, and got to the first human clinical trials.
Mhm, mhm. So let's kind of back up a little bit and talk about glioblastomas a bit, because that's kind of what the bigger thing that you have the experience with. And for those that may not be as knowledgeable about what a glioblastoma is, it's a very aggressive cancer. What else can you share about that for our listeners?
Yeah, like you said, it's a very aggressive cancer. It's a primary brain tumor, which means it originates in the brain and doesn't really metastasize outside of the brain. When a patient comes in, we were just talking before this about how patients get diagnosed. A lot of times it's a seizure, or a headache, or something. The patients can come in though and get diagnosed with a glioblastoma at that point. Um, but the main thing we'll talk about is the treatment for these patients. So once they get diagnosed with a glioblastoma, the way that they've been treated hasn't really changed in 20 years. And so the standard of care that they use right now was established in 2005 by a pioneering article by a neuro-oncologist named Dr. Roger Stoop, who found that there was a drug that had some efficacy in these patients when they used it in combination with radiotherapy. And so, just going back, when these patients are diagnosed, they'll typically, bring them into the OR. They'll try to do a surgical resection to take out what they can. Obviously, they need to be careful because the surgeons don't want to touch anything that's eloquent tissue that might affect, the patient's day-to-day life. But they will resect as much as they can. But after that, the patient will go on and get, radiotherapy in combination with chemotherapy. This kind of, you know, standard of care that was established, like I said, 20 years ago, that was shown to have, some efficacy. It improved survival by about 3 months in this paper that was published. Um, but after that, there's not a lot for these patients, and not a lot has been developed in the past 20 years that has shown to work. So, in terms of therapies, there's been one other approval, a medical device, but that's it.
Mhm. So, what's the big challenge that your research has been focused on?
Yeah, so the challenge that we're focused on, just going back to that surgery, is that when a patient has a surgery, they cut out what they can, but they always have to leave some tissue, and we always know that they can't resect all of the cancer cells that are left in the brain. And so it's those cancer cells that ultimately recur, um, lead to recurrence, lead to tumor regrowth, and then this is what leads to progression of the tumor, and makes the disease so fatal, really. And so what we're doing is disrupting the blood-brain barrier. So the blood-brain barrier is something that exists in the brain. It basically limits most drugs from getting into the brain. It exists for a physiological reason, I think, which is to protect the brain from toxins. But it also limits what drugs can be used and what drugs can be, potentially effective against this type of cancer. And so, um, the common number is that 98% of drugs don't cross the blood-brain barrier. And so we're left with this very small fraction, of potential candidates that may not be the best candidates, if you didn't have the blood-brain barrier there.
Mhm. Yeah, I remember when I was first a nurse, we had a two-bed step-down ICU that we would have patients, and some of them that were coming in for blood-brain barrier disruptions so that we could give them different medications because there is so much that gets blocked and doesn't get to the brain. So we would do it for a purpose to try to get those medications into the brain for that brief period of time where we could disrupt that little psychological barrier that's in there. So yeah, it's kind of crazy to see what we can do. So, given that, what makes Carthera's treatments kind of different and unique?
Yeah, the thing that's different about it, like you mentioned, so how were you guys disrupting the blood-brain barrier then? You guys were doing it in the clinic where you
So
worked?
this was 20 some years ago too. So it was in the hospital. Patients would come into the hospital, get admitted, and we would, gosh, I'm now trying to remember what exactly it was that we gave. It was some kind of medication to actually allow the medications to get through. And then we were monitoring very, very closely. So there was like one nurse assigned to that room with two people because they had to watch very, very closely to make sure that we didn't have any massive side effects. Again, 20 some years ago. I'm trying to drawing a blank a little bit on what we did, but
Yeah, there's
yeah,
usually
it was
one
very
thing.
early. Yeah,
There's mannitol, which maybe was what they were giving, I'm
that,
guessing.
that's
Okay,
I think
yeah.
that's what it was. Yes.
Yeah, I mean this kind of drug, causes some disruption, but it's kind of uncontrolled, and it creates, like you said, a lot of side effects. But it's been studied a bit, and shown some interesting things. Um, the difference that we're doing is we're not doing a chemical modification of the blood-brain barrier using a drug. We're actually using ultrasound, going back to ultrasound.
Yeah.
And so here we're using a technique that was first shown, about 25 years ago, by a researcher named Claire Bohinanen, who showed that you can use ultrasound, very low intensity ultrasound. So it's almost, pretty much a diagnostic level of ultrasound. You're not heating tissue, you're not creating other damage if you just apply the ultrasound. But if you apply the ultrasound to the brain in a specific way and you inject a microbubble, so very small gas-filled bubble, those bubbles will actually resonate in the vasculature of the brain in response to that ultrasound and cause, you can think of them, pulsating in response to that ultrasound. And that'll actually create kind of a mechanical stress in the blood-brain barrier. And this is what we can use to temporarily disrupt the blood-brain barrier. Um,
Interesting. Putting
yeah.
air bubbles in somebody's blood vessels have always been scary for me.
Yeah,
Admit.
it's yeah, what we're using is really an ultrasound contrast agent. So these have been around for a long time for imaging the heart and other things. And yeah, so we inject kind of something that already exists in terms of air bubbles. And then, like I said, use very low intensity ultrasound. Here in the case, we're using actually an ultrasound implant to deliver the ultrasound, which is a little bit, that's the unique quality I'd say about our
Mhm.
product, is that it's an implant, but we use the implant so that we can do it repeatedly. And so this is the big thing, is there's been a lot of different therapies for glioblastoma that have been tested in particular, and a lot of them are kind of one-shot therapies, like they've tried, we can go back to overcoming the blood-brain barrier. Like there's different ways of, when a surgeon's in there doing the resection, they can try to inject a bunch of drug, along the cavity, for example, or they can put in wafers. There's drug-loaded wafers that exist that you can put in the surgical cavity to try to get those cells that exist around. And a lot of these have been studied for decades. But like I said, they're not repeatable techniques. And so you can't really keep giving them, to really ensure that you're killing all the cancer cells. And so here we're actually using an ultrasound implant. And once we place it, then we can just turn it on when a patient gets chemotherapy. And so, we're giving a drug that's given every 3 weeks. And so every time the patient goes to get their drug in the infusion suite, we can turn it on, disrupt the blood-brain barrier, and increase the drug concentration really significantly within, this region that exists around the tumor.
Mhm. Mhm. When you said the whole part about replicating it, I kept thinking about the stereotactic radiosurgery when the patients would get those big halos put on, so we can get that exact spot every single time. So, out of curiosity, where does that implant go?
Yeah, so the implant, typically is placed kind of where the surgeon would normally do their resections. They open a bone window when they do surgery, um, and they'll place the implant, close to where that original bone window is. They may have to adjust it to really target exactly what they want to target, whatever tissue is really left where they think the recurrences can occur. But it's generally around that area.
So, kind of like when they would put the wafers in, it's a very kind of similar process to that.
Similar, but less invasive in a
Sure.
way,
Yeah.
we can say, because you're not putting anything inside the brain. So our implant just replaces the bone window. And so
Gotcha.
the patient still has their dura mater that's actually closed after the surgery, and the whole implant rests extradural. So, between the skin and the dura mater is where the implant is going.
Fascinating. Does it have to come back out then at some point?
It can. We've had some patients have had it, taken out if they go in for another surgery. I'd say most patients generally don't want to have another surgery just to
Mhm.
have the device removed. But we've also had patients who have kept it for quite a long time.
Okay. Okay. And is it turned on and off kind of like a pacemaker would be, like with a magnet, or how does that work?
Yeah, so we can't actually use techniques like that because the whole implant has to be MR compatible. And
Sure.
so that makes a lot of limitations on how
Yeah.
you can design a device and the materials you can use and having batteries and all this kind of things. And so there's no power source in the device.
Okay.
We really just have the ultrasound emitters within the device. Um, and we plug in the system. So we have a little port, and maybe you're telling me you're a nurse. Maybe I don't know if you ever accessed kind of
Yep.
a, yeah. I guess a portocath that we can
Yep.
call. Yeah, these
Yep.
kind of things, or an Ommaya reservoir,
Yep.
typically used in patients. And so this is the same principle. So there's this, you can actually see it protrudes a little bit. This is just a 3D replica. It's not the real
Sure.
implant, but it protrudes just a little bit. So you can feel it under the skin. And when you palpate, the patient, you can feel this little port, and then you can plug in a needle basically that plugs into this port and makes a connection to the implant. And so
Yeah.
we supply the power that way from an external computer source that drives the whole implant.
That's very cool. Very cool. Um, Have you had a lot of patients that have undergone this then? What kind of things are you finding so far?
Yeah, we've had a lot. So we'll just get to our clinical trial. We're in a phase 3 clinical trial right now. And so we've done a lot of clinical trials leading up to this point. Obviously, we had a first generation system. We treated the first patient in 2014. And these were some of the first results of using ultrasound to disrupt the blood-brain barrier, which others have done now with other devices, but we were one of the first ones to show that it could be safely done. We published that result in Science Translational Medicine in 2016. And this really established the safe parameters for disrupting the blood-brain barrier in humans. And after that, we've developed kind of a more sophisticated version of the device, a little bit larger to cover a bigger portion of the tumor. And this is the device I'm holding, the replica now. It's called the SonoCloud 9. And now with this device, we've done 3 really phase 2 trials in the US and in France, and published 2 of those trials recently in the past 2 years. And now we've launched our phase 3 trial just last year.
Very cool. Very cool. And I'm assuming good results then if we've gotten that this far.
Yeah, yeah, very encouraging results. We've we've seen in our phase 2 result paper that we published last year, and we published this in Nature Communications, our phase 2 article with this device in recurrent glioblastoma patients who are getting treated with our device plus carboplatin, which is the chemotherapy that we're pairing it with in this case. And in this article, I guess to give you some context, maybe you probably already know what's the median survival for recurrent glioblastoma patients is very low. So it's anywhere from 6 to 12 months, we'll say, depending on the patient status. In our phase 2 trial, we saw a median overall survival of 14 months, which we're quite excited about. We also looked at different metrics around how the tumor evolved and how it grew in patients that were given, on this trial. We actually had some different cohorts where we varied when we gave the chemotherapy, and we saw some interesting differences in terms of tumor control between these 2 groups. So we kind of found the optimal way to give chemotherapy relative to the sonication to disrupt the blood-brain barrier. And in this group, that we were excited by these results.
Yeah, I was going to say when we were talking earlier, and you said that the previous treatments gained patients about 3 months. I don't think everybody really realizes how short of a lifespan this is when patients get this diagnosis. It is a very grim prognosis because it is so aggressive, and people are so typically very affected by the time they get the diagnosis. It's not something that comes on slowly. So gaining those extra couple months on the median is that's pretty cool, remarkable.
Yeah, and I think the median is a little bit, we always quote the median, but
Yeah,
this doesn't always give it justice to the fact that the patients who respond to some of these therapies might be getting 6 months, 12 months or more
yeah.
of benefit. But there's always patients that don't respond to to drugs and oncology in general, and so we know that there's always going to be non-responders as well. And so
Mhm, mhm. What is the hope of all the research that you're doing?
hmm. Yeah, I've been asked this question a lot recently, and I think that the hope is a cure. I think
Yeah,
that the hope is always a cure. If you're working in cancer research, you want to cure cancer, and but I think a lot of cancers have become chronic diseases. I mean, I have a friend with lung cancer, and he's on drugs, but is stable and doing well, and the doctor, probably just will keep switching drugs, and it'll be a chronic disease almost for him, which is amazing because a decade ago that might not have been the case.
mhm.
Uh, glioblastoma we've talked about hasn't changed much in the past 20 years, unfortunately. And so I think that hopefully now we're at a stage where I think all the pieces will come together, um, to move the needle a little bit more.
Yeah, yeah. Are you working on any other research projects, similar or different phase types of things?
we have a lot of research going on. So we have this phase 3 trial, which is, you know, your listeners probably know, but we need a phase 3 trial to really show that our treatment can beat the standard of care, that it's better than what's out there and what these patients get. And so for recurrent glioblastoma patients, the standard of care in the guidelines, general cancer guidelines, is almost like patients should just go on a clinical trial because there's not a lot of options. There's one drug, a couple drugs that sites give, but generally, if you're going to like a site that has a lot of clinical trials, they'll try to put most of the patients on clinical trials because this is probably the best chance for getting a benefit versus what's out there right now. Versus other cancers that might have a second, third, fourth line of standard of care that we know have drugs that are somewhat effective. Um, so yeah, so this is really our first step is to get an approval with this drug in this indication. But after that, the great thing about our device is that we can deliver any therapy, almost any therapy, and so that's a big spectrum like we talked about. And so we have other trials going on to start looking at some of those other therapies. We have a trial that's looking at immunotherapy with Northwestern. So we have a great collaboration with the team at Northwestern and have this trial with immunotherapy, which is so far they've mostly failed in glioblastoma, unfortunately, even though they've shown a lot of results in other cancers. But checkpoint inhibitors, this is a class of drugs that had some very large failures in glioblastoma. Um, so we're exploring some different ways of giving those and maybe delivering them better and trying to see if there is, a potential signal, potential benefit for these patients. And then we're exploring we have collaborations with all kinds of academic institutions between Europe and the US that are testing out new drugs, new therapies that could be used, with our device going forward.
Mhm. From someone who does the research then in multiple areas, are there any limitations when you're doing research outside of the US than bringing those results here or trying to kind of double up at the same time doing research in other places? Because I know our FDA is very different than other organizations around the world.
You're saying with the FDA being different? Um, yeah, I would say, the FDA is actually the clearest kind of regulatory body now between between the US and Europe. The FDA has been really wonderful to work with. I mean, we've had great interactions with them. They give clear guidance and feedback when you submit questions to them. They can set up a meeting. You can discuss things with them. It's not always the case in Europe where you can, we've had some issues with some different regulatory bodies. It's taken longer to get some countries open on our pivotal trial. And there's kind of a gray black box where you're waiting for someone in an office to stamp something to open your trial. And you're not quite sure how to make that, happen. And in the US, it's a little bit more clear, I would say, at least right now it is. Yeah.
Sure. Well, that's
Hopefully it
cool.
stays that way.
Right. I hope so too. I've always been curious how that works when you're doing intercontinental research, essentially. So kind of cool to be partnering on that and trying it out in different areas of the world, so that you can actually kind of expand that and say, well, it's not just the U.S. population we were working on; it was others as well. So that's kind of cool.
Mhm.
Very good. Do you have any other events or projects you'd like to share with our listeners?
No, like I said, I mean, we have a lot of programs ongoing in glioblastoma. I think this phase 3 trial we talked about is open in the US and then it's open in Europe. It's open in see if I can remember all the countries, but it's open in Spain, in France, in the Netherlands, in Germany, in Italy now. It's going to be open in Denmark and Sweden as well. So we have pretty good coverage across Europe as well for the trial.
Yeah.
There's more information on sonobird.eu for this clinical trial, this phase 3 trial. We're also looking though at other indications beyond brain tumors. And so we talked about this issue of drug delivery, and it's something that persists across, any indication you're trying to treat in the brain, be it Alzheimer's or Parkinson's disease, or ALS or other, you know, brain diseases that really also haven't had a lot of progress, I would say, in decades as far as therapeutics, potentially because of this impediment.
Yeah, very cool. Where can people follow if they want to kind of see what's going on with the latest research you guys are doing?
So we post regular updates on LinkedIn's a great place. We also have information on Blue Sky. If you just follow Carthera, which is the name of the company, it's Carthera. Carthera.eu is our website. But yeah, you can follow us on LinkedIn, get more information about what's going on. We'll post regular updates and news and things going on.
Very cool. I will post those links in the show notes as well so people can find those easily and not try to have to write anything down while they're driving. Uh, yeah. Any last little bits of info or wisdom you'd like to share with our listeners before we wrap up today?
Um, no, I mean, I would just say, I hope we're on the cusp of something. I think we've shown that this is a new approach for drug delivery. It's something that's safe. It's been used in a lot of patients, and I think now hopefully we can bring it, across to the broader population once we complete this trial.
Mhm. Mhm. Yeah, I'm excited to see where this goes. Like we were saying before I hit record, I've been working in neurosciences since 1999, essentially. So there's been a lot of things that have not changed in that time frame. And I'm always excited to see the newest, latest, greatest, and whether there's something else coming along the pike that might actually make a difference for patients. So good work on that.
Great.
Yeah.
Yeah.
Thank you so much for joining me today.
Yeah. Thank you so much for having me.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.